hypertrophy, sir.
Okay.
In this,
there is a right atrial, appears right atrial enlargement as
yes,
evidenced by P wave prominent in LV.
yes, sir. In lead 2, sir.
Okay.
Yes, sir.
So now you read.
Sir, this is the oximetric data which is given. First of all, the femoral arterial saturation, ascending aortic saturation is 62. It suggests that this is a cyanotic condition, which was obvious from our history also. So the SVC saturation is 48 and IVC is
Grossly desaturated. 62
grossly
is
desaturated.
almost very.
Yes, sir. So he is grossly desaturated. The SVC and IVC saturations are also less than expected.
So if you have SVC saturation of 48, what is the normal SVC saturation?
Sir, the normal SVC saturation should be around 70 to 75%.
So that means why SVC saturation is very low?
Sir, as we can see that the ascending aortic saturation is also 62, it means that it is grossly cyanotic condition. So we expect...
So to maintain normal cardiac output, always there will be O2 extraction, which will happen significantly. That is the reason you will see the arteriovenous saturation difference. Normal arteriovenous saturation difference is 25 to 30.
Yes.
In case of low cardiac output, heart failure patients, severe pulmonary hypertension, or hypoxemia patients, the SVC saturations will be significantly dropped. So
Yes.
these are all compensatory mechanisms in any of these congenital heart diseases and also in human body. That's why the vessels also sometimes small to medium sized vessels will be dilated. In children, SVC also sometimes can be dilated because of the very low saturations. So that is probably one of the reason why you have SVC in the X-ray is dilated also.
Okay, sir.
Okay, go ahead.
Yes, sir. And then we do not see any step up at any significant step up at RA or RV level, but the PA saturation is extremely high, which is 87. And in comparison to the ascending aorta, the PA saturation is higher than aorta. It signifies that there is transposition physiology in this case, according to oximetry, sir.
Very good. So you can clearly see here the schematic diagram which is given here. Very nicely seen. This is the right atrium and right ventricle and ascending aorta, whereas pulmonary veins, left atrium, there is some amount of shunt here, and then to the left ventricle and pulmonary artery. Okay?
Yes, sir. Yes, sir.
Now you can see the pressures. You can read continuously pressures.
So in the pressure sequence, we see that the RA pressure is normal. A wave is 6 and the V wave is 4 with a mean of 4, which is normal. The RV pressure, systolic RV pressure is 78, which is higher than expected, with a RV EDP of 6, which is normal. Then we move on to the PA, sir. Then the aortic pressure is normal. Systolic is 89/52 is diastolic and mean of 66. The LA pressure is normal. A wave is 8 and V wave is 10, which we expect. And since the V wave is not higher than A wave in RA, it signifies that the interatrial shunt is not large.
Okay.
And sir, the LV pressure is 80/6, which is normal. So it's with this transposition physiology, there is.
What is the PA pressure?
Sorry, sir.
What is the pulmonary artery pressure?
The pulmonary arterial pressure is normal, sir. It is 20/11 with a mean of 16.
What does it indicate then?
It indicates that there is pulmonary stenosis along with this, sir.
Okay.
So the LV pressure is not transmitted to the PA. So this summing up whole, this is a TGA with a VSD and a restrictive interatrial communication with PS, sir.
Okay. What is your basis to tell that there is a VSD?
So the pressure of the systolic pressure of the RV and the LV are same, sir. It is 80 and 78. So it means that there is a large unrestricted VSD, sir.
So isolated pulmonary stenosis, is it common in TGA or it is rare without VSD? What are the two different types of LVOTO in TGA?
Sir, it can be with PS or it can be without PS, sir. And if it is without PS, then it will be an increased pulmonary blood flow situation. So it will go into pH much earlier.
No. Two different types of LVOTO. One is dynamic, second is fixed.
Okay, sir. Yes, sir.
So in case of dynamic LVOTO, usually the left ventricular pressures will not be this high.
Okay, sir.
And PA pressures will not be reduced. Whereas the fixed obstruction due to valvular, subvalvular membrane or muscle, that is common in case of TGA, is associated more than 90% of the situation with ventricular septal defect. It is very rare, only LVOTO without VST in TGA.
Okay,
fixed obstruction.
Okay, sir.
So read this angiogram now.
Sir, this is an angiogram which has this is the AP view. The course of the catheter is a pigtail catheter. The course of the catheter is from the IVC into the RA into a ventricle, which is a smooth wall. Seems to be
how did it go to
sorry.
ventricle?
No, sir. So IVC into RA into IVC into RA into RV into VSD into LV, sir. It is in the ventricle into the left ventricle as is a smooth wall, and we can
through VSD or is it through any other communication which is common?
Interatrial communication, sir. This is also common. That is also a possibility.
That is the commonest thing.
Yes,
you can see the left AV wall. Can you see the left AV wall here? The catheter is going through the left AV wall. That is the negative contrast. You can see the left AV wall.
Yes,
so the catheter pigtail is coming from the inferior vena cava, right atrium, foramina ovale, left atrium, through left AV wall into the smooth walled, smoothly trabeculated left ventricular morphological ventricle. Okay, then.
And then we can see the filling, and this morphological LV is filling the bilateral PAs first. We can see, and then filling of the aorta is also seen through the VSD, RV, and into the aorta, sir. So this is suggesting that the LV is giving rise to PA, and there is good peripheral arborization of bilateral lung fields are there, sir.
Very good. So this is a different view. You can see the ventricular septal defect.
Yes,
so
sir.
Now your questions are, what is the effective pulmonary blood flow in a DTJ VST PS? What is the effective systemic blood flow? What are the two communications which determine? Can you briefly explain, or shall I take next class?
Sir, the effective pulmonary blood flow will depend upon the amount of pulmonary stenosis which is there, and it will also depend upon the interventricular communication which is there, sir.
Effective pulmonary blood flow will not be decided by the pulmonary stenosis. You please remember that. Okay, effective pulmonary blood flow, but the amount of blood flow which is coming back from the pulmonary venous return to the left atrium, left ventricle, most of the blood will go to the pulmonary artery only. It will not be pumped into right ventricle from there to aorta, because right ventricular pressures are systemic pressures. The right ventricle pressures and left ventricle pressures are more or less equal. So there is no way that the left ventricle is going to pump into the right ventricle, not into the pulmonary artery.
Okay, sir. Yes,
so
sir.
That is the reason even in DTJ, VST, PS, interatrial communication is going to be very crucial. So if you have a good interatrial communication, you will have admixture even at the atrial level. So you will have effective pulmonary blood flow as well as the systemic blood flow, oxygenation, everything will be improved. Anyway, I am going to give talk on the hemodynamics in next class, that is tomorrow, about all those things. Okay, thank you very much, Muftaja, and this case yesterday's discussion. So today, let us see. We'll go to other topic today. So today we are going to discuss about the pressure and resistance. Maybe I may stop at the resistance definition because we need a lot of time for all these things. So lot of people are attending. I am happy close to 100 people are there today. I think so far 99 students are attending. So first of all, when you are in the cath lab, it is essential to record the pressures and analysis of the pressure waveform. What is a pressure? A pressure is a force exerted per unit area is called as pressure. That is the fundamental definition. These definitions, you all should by heart these definitions and understand completely. A force is transmitted through a fluid medium as a pressure wave. That is, the number of cycles occur in 1 second is called as a fundamental frequency. The definition of ventricular pressure wave, a complex periodic fluctuation in force per unit area, usually it is dynes per centimeter square. There are two types of pressures which we are actually measuring. You all should know that. See, I would like to see that people should do parallel chatting so that I can chat box so that I can take your questions and answer, because this is going to be somewhat didactic lecture for next 30 minutes today. A pressure is essentially what you are measuring is one is called as kinetic pressure. Kinetic pressure is a movement in the body. You are measuring the kinetic pressure, that is the pressure which is circulation of the blood. Second is hydrostatic pressure. Hydrostatic pressure, the pressure exerted by the fluid within the body in the chambers. So these two are the important pressures which we measure inside the body. So this is how the first pressure was recorded by Dr. Stephen Hales, and you can see that he connected a tube to the horse jugular vein and measuring the pressure way back in 1730. That's how the concept came to measure the pressures. So in your cath lab, you have a hemodynamic system here, which is connected to a manifold and transducer and then to manifold. The manifold or a three-way connector is connected to the fluid filled catheter system, which you are checking pressures in the heart. So now you see that a hemodynamic catheter in a different chamber detects the kinetic pressure as well as the hydrostatic pressure, which will come through the fluid filled catheter system and then goes through the manifold three-way and then to the a transducer here, which has got a membrane and a Wheatstone bridge here, which actually converts the kinetic energy into electrical signals. So the pressure gauge, this one is the transducer. Inside that, there is a membrane here. That is called as a diaphragm. This membrane is developed by the biological material or a polythene material which doesn't have any resistance at all and which is connected with 4 resistances. So what will happen? The kinetic pressure, hydrostatic pressure, which is coming into the catheter system, into the three-way, directly going to hit this diaphragm or membrane here. That will go into these resistance or electrical strain gauge where the pressure, hydrostatic kinetic pressure will move the resistance will be converted into electrical signals. So that is how it will be conducted. So the pressure is going and hitting the diaphragm here. It moves through the resistance and through the Wheatstone bridge, it will go and give the signals. So you all must have done experiments in your physiological laboratory where the frog heart pressure will be connected with a fluid filled catheter here, which goes and hits a membrane, a dome, and then mechanically the lever will move and then touch this kind of a roller board, then it will give the pressure in the mechanical form itself. The technician will wash this, process this, and will give you the paper print. Over the period of time, with this conversion of the kinetic signals into electrical signals, and then again in the form of a printing was developed and then worked for long time. But it has got lot of fallacies of coming the many artifacts even with the slightest movement of the catheter and electrical signals which are unfiltered was giving lot of problems. That's why now everybody switched over to this kind of conversion straight away from the kinetic energy will be converted into electrical signals in the computer. You will get the proper transducer or a proper waveform. So what you need to do in the cath lab? This is the stepwise approach of recording the pressures. First thing is calibration, leveling, zeroing, fluid filled catheter system, aspirate all catheters, check connectors and bubbles, and I'm just muting so that it will not cause any. Can you hear me now?
Yes, sir.
Yes, sir.
Okay. Aspirate all catheters, check connectors bubble, catheter positions. This is going to be your today's lecture to some extent, first half. How to calibrate a transducer system. Most of the people, they are not doing, believe me, they are just checking the transducer, just recording it. It is absolutely wrong. What you can do is, you take a sphygmomanometer here, connect your sphygmomanometer with a three-way connection to the, you can see that which is connected to the your pressure wave monitor system and inflate to 100 millimeters of mercury. And then see your monitor whether it is mechanically calibrated or not. If it is not calibrated, after inflation to 100, you ask your technician to accept that as 100. Then the pressure transducer system is properly calibrated. This you have to do periodically. Probably I prefer to do at least every week. If you don't do that, your pressure transducer system is not calibrated properly and you will have lot of artifacts you will measure either high or low. Second point is leveling. How often you are doing leveling? This is essential to check the transducer system to the mid-axillary area here. So take a long scale, connect a water ampoule, a big water ampoule. You will have bubble. You see engineers or people who are doing construction work, they will have level manometer. So you keep the level manometer adjusting your transducer system to the mid-axillary line. So once the bubble comes horizontally, that is the point where you are going to fix your transducer system. Otherwise, your transducer is going to be either low level or high level. I will tell you what are the problems of that also. So this leveling is mandatory before you do cardiac catheterization. So this phlebotaxic axis is nothing but where SVC RA junction in the RA posteriorly, the SVC blood comes here, IVC blood comes here. There is a point where blood is static. So that point will be taken as phlebotaxic axis. This is an arbitrary, approximate. It's not possible. Then you have to dissect the art. It is impossible. So once you do leveling, then you have to go to zeroing. What will happen if you don't do proper leveling? You see this. This is the cardiac chamber. For an example, this is the mid-axillary line phlebotaxic angle. Your pulmonary capillary wedge pressures are 12 millimeter. Suppose you are doing in a obese patient, your transducer is much lower than the mid-axillary line. Your pulmonary capillary pressures are going to be highly, erroneously, significantly giving artifact here, which is going to be around 20 millimeters of mercury. Whereas in a neonate, if you are not keeping it properly, an infant, your wedge pressures when you are doing any cath work, catheterization, your capillary wedge pressure is going to be low. So that is the reason you need to have properly placed transducer system which corresponds to phlebotaxic axis. Then zeroing. So what will happen when your transducer is coming from high pressure to low pressure? The air will be entrapped into the transducer system. It will be open to the atmosphere. So your actual zero may not be corresponding to the zero. That's the reason once you do calibration leveling, then you open the pressure transducer system to the atmospheric pressure with a fluid filled system. You fill the transducer with saline, which is equal to the viscosity of the blood supposed to be. There will be marginal difference, but we don't take into consideration. Then you see if there is even 2 to 3 millimeters of mercury difference also, it is going to cause a serious problem in terms of calculation. Here you can see close to 12 millimeter difference is there. So that you need to eliminate. You have to accept it as zero, then properly you should make it as a zero. Then fluid filled catheter system. When you ask your nurse or fellow, he will give catheter just like that. That is absolutely wrong. The catheter will have air in that. Suppose I ask you to flush the catheter, what you people are doing is, you are just flushing the catheter, leaving the three-way open and you are giving. That is again a wrong method. How to do a fluid-filled catheter system or flushing a catheter system? You see here. This is the catheter. I will go from here. That is the catheter, and which is connected to the three-way and then to the transducer system here. So now you are flushing three-way. After flushing the transducer, you flushed that. While flushing, you are actually closing it properly. This is called as fluid-filled catheter system. Again, you are flushing the transducer. See, your technician is accepting it. After that, you make it like that. So now your entire system is filled with fluid. So your pressure waveform is going to be absolutely perfect when you do the pressure waveform recording. So now the problem is bubbles in the system, clot in the system, a three ways which are not properly locked, if you improperly locked or broken three-way, or it is leaking, your waveform will be horribly, you will get it. So improper transducer height, improper calibration, and presence of bubbles, clot or leak are important maneuvers which you need to check prior to the recording of your pressures. Second is a catheter characteristics and the tube characteristics. You can see here the tube, pressure waveform, pressure recording tube, which is semi-compliant tube. You can't have completely compliant tube. Completely compliant means when you flush it like a balloon, it will distend. If you use that kind, your pressure wave will not be recorded. Similarly, if you have a stiffer connector, like you use it for the angiogram, which is different tube compared to the pressure wave, you will have high rigidity and your system is going to be overdamped. So your catheter and tubes are going to be very essential to check it, what kind of catheter material which you are taking, how you are going to record the pressure. So check the connector. See here, the connector is done without three-way. That is good, provided there are no bubbles, no clot. Because you are eliminating one connection, so you will have complete pressure recording. Most of the times what we do is we put a three-way. Suppose accidentally there is a clot in the catheter, there is a bubble in the catheter, you will have an edge to aspirate, flush it. So if you are perfectly correct, then you can use this without a three-way. But remember that the connection should be good and bubble should not be there. Similarly here, when you are checking the pressure, this is the transducer. Here you have two connectors, one is open to the atmosphere, another is going to connect to the pressure. So you have multiple connectors. It is your duty to check it before rather than blaming the technician always. So you have two transducer system. One is fluid filled catheter system that we all do it. Second is a Miller catheter where transducer is located in the catheter at the distal tip. You can directly measure that. But it's very difficult to get that one, number one. Number two, it needs a higher French and also a lot of artifacts are there. So Riki Nishimura, you all know that from Mayo Clinic, he is a pioneer in recording a lot of hemodynamics using the Miller catheter. So the transducer is located there. This is the transducer wire. Sometimes they put it, and directly you can connect to the hemodynamic monitor and get the pressures. So you can see the fluid filled and Miller catheter. You can eliminate some artifacts and you can produce artifacts also with that. So it is not that easy to do that, and it is unwarranted. Number one, expensive. Number two, we don't need it. But from the exam point of view, you should remember that this is what it is. A double lumen catheter. A double lumen catheter is a catheter where you can measure the distal pressure as well as the proximal pressure. Or you take two catheters. One you can measure the distal, another you can measure the proximal. So the problem with the double lumen catheter is you will have a damp trace sometimes. Whereas two catheter system is very good when you are measuring LV and iota, but the problem is you need to properly calibrate both the transducers which you are using it. So if you look at these are the pressure waveforms which are recorded using the fluid filled catheter system in the right atrium, right ventricle, pulmonary artery and wedge. As you see that the diastolic pressure of right ventricle, endostolic pressure and diastolic pressure of pulmonary artery. Diastolic pressure of pulmonary artery will be always slightly higher than the endostolic pressure, and wedge pressures will be slightly higher, that in order to have the proper circulation and the prevent of regurgitation in the semilunar walls, all that, which you all know that. So we are going to discuss all those things and how we'll have various pressures and all. But I want to tell all of you, you should aware of this Wiggles diagram completely. When you are recording a pressure waveform, here you can see that a ventricle pressure, for an example here, this is where the AV valves which closes. If it is left ventricle, mitral valve. If it is right ventricle, which is tricuspid valve. This particular ascending limb is called as isovolumic contraction. Rarely you may see a small dot where aortic valve opens, but most of the times you won't appreciate that. Similarly, on the right side, pulmonary valve opens at this point of time. So this point of time is called as, from here to here, isovolumic contraction. Here the contraction happens between closed AV valves and closed semilunar valves. Once the semilunar valve opens, the blood will be ejected into respective arteries, and this is the first phase of ejection and second phase of ejection. Then aortic valve closes here, then you will definitely see a notch here. Some people call it as incisura also. So this is called as ejection. Then this descending limb, this is isovolumic relaxation phase. Then you will have a diastole here. So you please remember this with reference to the cardiac cycle, pressure waveform, as well as the ECG. So now coming to the catheter system, while recording, what are the problems you get is, what is actually a damping? A damping is nothing but dissipation of the energy. You have sine wave form which is coming in the electrical transducer system. Suppose you have high resonant, low resonant, tubes are not good, air is entrapped, clots are there, or your catheter is going and hitting the muzzle wall of the ventricle, then waveforms will be damped. The energy will be dissipated from the catheter to coming into the transducer system. So when you have a proper dissipation of energy of oscillation of a pressure management system due to friction offered by the various tubings, connectors, everything. Suppose you have a lesser friction, the pressure will go directly and hit the membrane and then will be transmitted to the Wheatstone bridge and you will get a proper signal. Suppose if you have so many problems, high viscosity, bubbles, clot, all these things, and your tubings are not good, then you will have various problems. If fluid will have greater viscosity, a smaller catheter radius, and less dense fluid, that's why sometimes in anemia, hyperdynamic circulation, you will see greater damping. So a damping is nothing but 4 into viscosity of a fluid by fluid density into catheter radius. You don't need to calculate all those things. This is only for your information, but you should understand the definition of a damping. A natural frequency means frequency at which fluid oscillates in a catheter when it is tapped. Frequency and input pressure wave at which the ratio of output should be equal. Then you can call it as a natural frequency. You all should read this in Grossman, which is given wonderfully very well. If you have a shorter catheter, a larger lumen tube, or anemia, fluid, lighter fluid, all those things, then you will have higher frequency, higher natural frequency. So in this process, what will happen? You can have a normal damping, that is called as normal waveform, under damp or over damp. So if you have over damp, your pressure wave system will be, waveform will be altered, will be blunted. You will get improper signal and you read it that low pressures. So that's where flushing of the catheter, eliminating these bubbles and clots are important in this. Here, under damp, the system is not properly damped. You have a problem of hyperdynamic circulation. Fluid is directly hitting the catheter. You have a short catheter, rigid tube. Then directly pressure is going and hitting the transducer. You have some kind of artifacts here. So what you do here? You create little bit of bubble here. You put a small bubble here to optimize the damping so that you can eliminate this overshooting of the pressure wave. Whereas here, because of the clots or leaking of the pressure in the connectors, you have this over damping that you need to check the connectors and you need to check the clots and other things are there. A damped trace means under damp is a wide, slurred, flattened trace. That is again due to what I told you, catheter kings, clots, injection pores, all these things can cause this kind of problem. Similarly, resonate, that means overspiked tracing, occurs long tube, probably I told you short tube earlier, long tube, overstiff, non-compliant tube, like injector tube you use once and then check it pressure in the lab when you want to really would like to know that. If tube doesn't have a semi-compliant tube, your pressure waveform is going to be spiked very much. Increased resistance, reverberation due to the tubing, all these things can cause this kind of a problem. Can you please erase the drawings somebody is doing? So what you do in the lab is a fast flush method. A fast flush method, what you will do is you give a syringe, flush it very fast, and then see whether you are getting a waveform like this. If you are getting a flash method waveform like this, that is optimal damping. If you are not getting a waveform which is going up or down below the baseline, that is over damp. When you have multiple waveforms which are coming here, that is, it is highly resonant and under damp. That you do in the, actually, I'm just going to remove this. I don't know how to remove, but annotate. Okay, I'll use eraser. Probably somebody accidentally they have drawn it. Okay, all right then. This in the ICUs generally they do this kind of flash method and all. Generally we don't do in the cath lab this kind of thing. So now how to record a pressure? Anybody would like to answer this? Anybody would like to answer this? What is this transducer? What is this waveform? Arun, you please answer this. I know you ask a question, short tube causing over damping and all. Please answer this. What is this? You can open your microphone, no problem.
Sir, this one is RV, right ventricular pressure.
No, it is RA pressure. I have written the
RA, sorry, right atrial pressure tracing.
Okay.
There is what is happening is the A wave and V wave. Sir, the A wave and V wave appears unduly tall.
Which wave is appearing tall?
V wave.
because during the mitral stenosis, balloon mitral valvotomy, you are going to measure the V wave in case of development of the mitral regurgitation. There are a lot of criteria. What is the A gradient, what is the V wave and all, that is a special class which we can talk whenever we get. So in case of setting up a transducer system, you need to check the connectors and bubbles. So here you can see a trace with the bubbles is causing more artifacts here. You have many artifacts. So your pressure is going to be somewhat highly sensed by the monitor this and will give you the pressure. That's the reason manual recording is very important. Manual calculation is important. After flushing, you can see the left ventricular pressure, which is becoming better here. What is catheter whip artifact? I was having a lot of whip artifacts, but I did not put it. I took it from the library here. So when you have a catheter in a high pressure system, or you have more left to right shunt in case of VST, or there is a pulmonary regurgitation, you put a catheter in MPA, the catheter will move with the forward flow as well as the regurgitation. That time you will get a positive wave as well as a negative wave based on the catheter movement called as catheter whip artifact. So you all should understand this and you should eliminate that. To avoid that, you cannot, if you are using a balloon flotation catheter, inflate the balloon. If you don't inflate, it will jump it. If you are taking a catheter, non-balloon flotation catheter, you have to go a little bit distally to avoid this movement. So what is a reflected wave? What is peripheral amplification? I am sure that you all must have gone to beaches and then watched the tidal waves. What will happen in tidal waves? A wave will come and then will go. While it is going, another wave will come. This wave will go and hit this, and then the subsequent wave will become bigger. So the wave which is going back is called as a reflected wave. It hits the next preceded wave, which is going to give an augmented pressure. So how it will happen in the body? The left ventricle ejects into aorta. From the descending aorta onwards, there are so many vessels, iliac arteries, femoral arteries. So the waves which are coming from this vessels branches will go and hit that, will have the more reflections. So that is the reason when you measure this, the pressures from the ascending aorta, descending aorta, abdominal aorta, iliac arteries, femoral arteries, you will have an augmented wave over the period of time as you go distally. So when you want to calculate the pressure resistance or compare the pressure of pulmonary artery and aorta, don't check the femoral artery. Don't compare with the femoral artery and the main pulmonary artery. You will have wrong calculations. When you are checking the main pulmonary artery, you have to check only ascending aorta. Then only you get the proper pressure, proper calculations, resistance. So that is the reason we always measure left ventricle and aorta, and if you check that left ventricle and the femoral artery, you will have pressure differences in the femoral artery compared to the aorta. What is an end hole artifact? So you take a end hole catheter, go into aorta. Generally we don't do that. We always measure aortic pressure with the, you all know that pictal catheter. Sheath pressure will give high pressure. When you check the sheath pressure, it will go very spiky pressures and you will get somewhat higher pressures compared to your pictal catheter where you keep either in descending aorta or in the ascending aorta. Why? The pressure, the blood which is coming directly from the left ventricle will have a pressure in the beginning of my talk, first slide, I told you that the kinetic energy and hydrostatic energy. The kinetic energy which is coming from the left ventricle directly will go and hit the end hole of the catheter. That's why when you are recording pressure, end hole catheter in the aorta is not a good idea to record the pressure. That's why you always take the pictal catheter or Jensini catheter or MPA with many side holes, you check the pressure. So what will happen? Your end hole, the pressure which is kinetic pressure will be transmitted through the end hole, and you will get this kind of spikes called as end hole artifact. So what is catheter impact artifact? When catheter, you have a severe aortic stenosis, you want to check the pressure followed by the balloon dilation. You are using a right coronary artery catheter with only end hole. The catheter will go on to entrap in the hypertrophied myocardium here, and you will get a pressure wave which is very high and which has got this kind of contour with a spike, and you will falsely read that as a left ventricular pressure, and you have a femoral artery or ascending aortic pressure like this, then you spuriously will think that there is a high gradient and you tend to dilate that. That's where your catheter should be freely in the mid cavity of the left ventricle while you are recording, especially left ventricular pressure, or for that matter, right ventricular pressure in case of pulmonary stenosis when you are checking the pressures. So this kind of information, this kind of tracings you often see in the cath lab if you are careless about your recording system. So can anybody read this? This is a pullback from the pulmonary artery to the right ventricle. What are the important features? We have another 3 more minutes time, don't worry. We are going to continue all this. We would like to go slowly. Anybody would like to read this? Any volunteers? If not, Palak, Kalyan, Pavan.
Hello, sir.
Pavan, please read this.
This is a pullback hemodynamic recording, sir, showing there is a pressure gradient inside the right ventricle, suggestive of double chambered right ventricle.
So why don't you actually start from here? This is what is this tracing?
This is a main pulmonary artery.
Main pulmonary artery tracing. What is this? What is this?
It's an infundibular.
This is not infundibular. This is only spike. This is the pressure drop at the pulmonary valve. You will have an incisura. You will have pressure drop at the pulmonary valve. Then this is the right ventricular pressure. So this is the right ventricular infundibular. You can actually, yeah, I also agree. This is the incisura pressure. This is the infundibular pressure.
Yes, sir.
And this is the right ventricular pressure. Then what is this? What is this? So pulmonary artery pressure, this is at the pulmonary valve, then infundibular pressure, this is right ventricular contour pressure, this is again right ventricular body. Then what is this? You can see ECG.
It's an
You can see
ectopic.
ECG here. What is happening?
There's an ectopic, sir. Ventricular ectopic.
Ventricular ectopic.
So there is a happen ventricular ectopy. Why pressure drop is there in ventricular ectopy? It's a premature ventricular contraction. There is no preload to the right ventricle. Because there is no preload to the right ventricle, the ventricular pressure waveform is less. Then what will happen? There is a compensatory pause. What will happen? The preload will be increased. hypertrophic cardiomyopathy. So again, there is an ectopy which is not transmitted and post-ectopy potentiation. So there is a infundibulous stenosis also here after the Milind valvulotomy. So this is the normal left ventricle, left atrial pressures, how you record it in 40 scale to compare whether there is a mitral stenosis is there or not. This is typical left ventricular pressure, how you record. You can see the phases of a cardiac cycle, isovolemic relaxation, ejection, and isovolemic contraction phase. The pulmonary artery pressure with a lot of artifacts you can see there. A catheter whiplash artifact also there, and then aortic pressure. So after eliminating the artifact, you can see the pressure waveform here. So when you are taking a pullback from left ventricle to the aorta, you can see that the left ventricular waveform here nicely seen, and then you are getting the ascending aortic pressure. There is no gradient, and you can see the point of aortic valve closure there. Ascending and descending pressures there. So this is homework to everybody. You can take a snapshot of this. Or I will ask Kalyan to put this one. I am not going to read this. I am going to give you homework this. I am sorry for that. So Pawan, you can continuously speak. Tell me this particular tracing. This is
yes, sir. This is a pullback.
Please listen.
Yes, sir.
Yeah, go ahead.
This is there are two pressure tracings, sir.
Okay.
One is concurrently recording the aortic pressure. Other one is being pulled from left ventricle to aorta, sir.
Okay.
And left ventricle, during concurrent recording, there is a gradient between left ventricle to aorta. Femoral artery to LV. Around significant gradient is there, sir. I could not read the gradient.
This is aorta or
this
femoral
is
artery.
Femoral artery, yes, sir.
This is the left ventricle. Baseline, when you check it, the left ventricle to the femoral artery, there is a gradient.
Yes.
There is a significant gradient. Because this is 200 scale, the left ventricular pressures are 240. You can see it is 240. So the pullback is taken, keeping this catheter from LV to aorta.
Yes, sir.
What happened to the femoral artery pressures here?
Once the catheter crossed the aortic wall, femoral artery pressure increased.
Once the catheter comes out of the left ventricle, pull back. So in other words, when you cross the aortic wall in a critical aortic stenosis, there will be pressure drop. What is that called as?
Pressure, that is Caraballo sign.
So pressure drop when you have in a critical aortic stenosis, your catheter itself will occlude the aortic orifice, leading to the pressure drop is called as Caraballo sign. So what is this tracing? I don't want Pawan to answer. Any of the adult students are there, adult cardiology students? Anybody would like to volunteer?
Tracing of LV.
May I know who is speaking?
Anand speaking, sir.
Anand, okay, good Anand. Please go ahead.
ECG gated pressure tracing, sir, with
this is the left ventricular trace and the femoral artery simultaneous.
Yes, sir. It is a ECG gated pressure tracing, sir, with calibration up to 200. LV pressure is around 130. Aortic pressure. So on pullback from LV2 to aorta, there is a gradient between LV and aorta. Post-ectopic, there is a potentiation of LV pressure, which has crossed more than 200.
A baseline here, this is a femoral artery and this is left ventricle. There is a gradient here.
And gradient is there.
So there is, what is this?
Ectopic bed, post-ectopic
So
bed.
what happened during ectopy?
During ectopy, there is a less filling in the ventricle. So ventricular pressure is also decreased. Aortic pressure also decreased because of underfilling. Followed by post-ectopic bed, there is a potentiation of LV pressure. And at the same time, the aortic pressure has been decreased. This suggests dynamic obstruction, sir. Broken bro.
Systolic pressure.
Marrow sign, sir.
So what is the spike and dome appearance?
Spike and dome appearance because of rapid ejection in the early systole, the peripheral aortic pressure will show spike appearance because of rapid ejection, followed by dome because of dynamic obstruction.
So your homework is completely about what will happen to the pulse pressure, what will happen to the aortic pressure.
Yes, sir.
And what are the mechanisms of this broken peroxide?
Yes, sir.
Okay, so I will just give you a definition of resistance, that's all. Vascular resistance is probably you have a tube diameter here and another vessel diameter here. When the fluid passes from one diameter to another diameter, you will have resistance to the flow. That's a very simple fundamental thing I am talking to. If it is higher to the lower, then pressure will be increased. When it is lower to the higher, there will be pressure drop. That's also very simple. So to get derivation of the vascular resistance, you have a formula here. That is flow, either QP or QS, equal to pipe into pressure to the 4 by 8 fluid viscosity and length of the tubing. You don't do all these things, but you will calculate this pressure to pressure here. How you are going to calculate that we can discuss. So basically you all should know what is SVR, what is PVR, what is cardiac output, and how you are going to actually derive this by calculations. So you have to read only that. Tomorrow I am going to talk about case examples and some of the vascular resistance formulas, how we are going to deal with that. We are going to deal the second part of hemodynamic session, and some of the waveforms also we will talk tomorrow. Thank you very much.
Thank you.
If there are any questions, you can probably, we will take tomorrow more questions. We will keep more examples.
Actually क्या होता है, पोटेंशियल कॉन्टैक्ट बहुत जोर से कॉन्टैक्ट करता है, लेकिन जब वो कॉन्टैक्ट जोर से करेगा तो क्या होता है, पहला वाला ब्लड को ज्यादा नहीं पाएगा, इसलिए सिस्टोलिक प्रेशर